Hello, my dear friends, my dear colleagues. Welcome back to the Aligners Intensive Advanced Biomechanics and Adjunct Therapies. It's a huge pleasure for me to be here with you. My name is Daniel Ramos. I am orthodontist for more than 20 years and your host for this course. I'm very glad to be invited by the OIGS team. I'm super excited about their project, about all courses they have available. You can learn a lot in their platform. Be sure to look back at everything they have for orthodontics, especially with aligners, which I am proud to be part of this project. Okay, we are now in the second half of our course, right? Our 8 modules program. We already explained about the whole of facial area and functional driven digital planning for aligners, some important rules of biomechanical rules for complex cases, the use of skeletal anchorage, and we started the previous class, talking about accelerated orthodontics and bone modulation. Okay, so in the last class we talked about the non-invasive, the non-surgical approaches, and today we are going to start talking about the surgical approaches to facilitate orthodontic movement. Okay, so this is the beginning of our second half. I hope you are enjoying this course. Be sure to make all the questions you want during this course today, during this module or between the modules. If you want, you can write to OIGS team. They can forward a message to me, and I'm going to be at your disposal to answer all your questions. Okay, so we started in the last class showing these slides, right? Understanding that without the biomechanical rules we have a limit that we cannot cross in terms of force that we are applying, in terms of the velocity that we can move when we apply this force. So when we are talking about biomechanics, we get to a limit that normally we cannot cross. So with the years, a lot of doctors, they start investigating how can we promote a faster tooth movement, right? And this is one of my passions, to study this topic, and I started a long time ago, and I am responsible in Brazil, my home country, my hometown, where I live, to spread this concept about accelerated orthodontics. One of the doctors, right? Many others are talking about this, of course. And this technique today that we are going to concentrate is now a surgical procedure, okay? But the one that I consider the minimal invasive possible that can be used in our routine in the clinic, which is this one in the corner here, we call micro osteoperforations. So the last class we talked about this device, high frequency vibration, the non-surgical approach that I consider the one that is worthy using in my clinical experience. Pretty sure there is other devices that probably good results too, and this is my clinical opinion here. And the surgically facilitated orthodontic treatment that is more commonly known for the corticotomies that you are seeing here in this video with the guide, okay, also has some different approaches inside this topic here, okay. All of them, they share the same principle, which is create a trauma in the bone to promote an inflammatory response, bringing the inflammatory cells responsible to create bone, but also that they are the same that are going to help the orthodontic movement. And since we are doing orthodontics, we are stimulating movement, these cells are going to get together to increase the velocity and the quality of the bone remodeling process. Okay, so the whole goal of the evolution of these techniques is to find a technique, a way to promote this trauma in a minimal invasive, in a minimal surgical procedure as possible that can generate this effect. Okay, so the micro osteoperforations are a technique that was developed by the New York University, United States, and then in partnership with Propel Orthodontics, they launched this device that you are seeing here, right? That is pretty much a mini screw in the tip that has a design to promote trauma in the bone with a lot of resistance. And this trauma is going to send a message to our body saying, oh, here we have a fracture. So we need to bring cells here to promote a better process of remodeling this bone. And this is how this technique evolved. We started a long time ago, and I'm talking probably in 1890 something, okay, a long time ago, with studies showing that creating a trauma in the bone can generate this effect. And then with the Wilco brothers, they developed the corticotomy and the Wilcodontics, as they call the technique, okay, and this technique is considered efficient to promote a better bone remodeling and a more efficient movement, although we created a small window of effect because at the time they only treated with braces, right? And the activation process of the braces, that is normally from once every 30 days, delayed a little bit the new activation, and the effect don't last so long, okay? And then with time, simplifying the technique, avoiding open flap, and also avoiding incisions with the micro-osteoperforations, we now can say that there is a minimum invasive technique that can be used for a orthodontist and can be used for all cases, because this is perfectly accepted by the patients, okay? But let's discuss a little bit more now about the biological principles of this technique that can be shared with all the others that I mentioned in the previous slide. First thing to mention is that we have plenty of studies of all the PIRAM evidence, right? Since animal researches to clinical cases to systematic reviews and meta-analysis. I'm just using these ones. You cannot read probably, but just for you to have a reference, that we have studies exemplifying and proving all these areas. Studies from the Wilco brothers showing that for cases like these, that we need to expand and move teeth to a position that normally we cannot do because we don't have enough bone, by opening flap, doing some corticotomies and adding this bone graft. This is the topic for the next class. We can speed up the tooth movement in 2 to 4 times, okay? So, and it probably, it lasts about 4 months. This is a great article by Vincent Kokish, a very famous orthodontist. So by doing this trauma and doing together with orthodontic forces, what we're going to do is to increase the inflammation, okay? The inflammation that already is there, okay, because of orthodontic stimulation, okay? And with the trauma in the bone, the micro-osteoperforations or the corticotomies, they're going to increase locally these inflammations. What is the inflammation? Is the presence of the inflammatory cells, the one that is responsible, the most important one responsible for the orthodontic movement is the cytokines, the cells, okay? The ones that can differentiate and generate bone remodeling and tooth movement, allow tooth to move. So we are talking that in one side we can stimulate our biomechanics in a limit that we can be very efficient, but we cannot surpass by applying more force, okay? Now we're talking about the other side. We are promoting an effect in the bone, so it can remodel faster in the same amount of force that we apply in our biomechanics, okay? This is the interesting part. A lot of studies shown that when we don't have enough cytokines, we're going to have a decrease in the rate of tooth movement, okay? So a lot of doctors and researchers already tested the use of anti-inflammatories medications to decrease tooth movement, and they prove that it can decrease significantly. So here, the first tip for this class today: when you are talking about orthodontics with your patient, investigate if your patient is the kind of patient who likes to use medications for any reason, right? And let's be honest, everyone does. Everyone do, right? For example, this weekend I play paddle, which is kind of a tennis here in Spain, very famous. And then in a tournament, and the next day my feet was awful, a lot of pain, and I took there some anti-inflammatories just to reduce the pain. I did it without consulting any doctor, right? Because I was feeling pain. Imagine your patient if it's not doing this. And sometimes we can see that the movements are not happening maybe this is the kind of situation that the patient is using a lot this kind of medication. So when we are going to start orthodontic treatment, it's important to investigate these in case the patient say, yes, I'm used to use this kind of medication. Please let the patient know that probably it will create some reducement, some decrease in terms of the rate of tooth movement and can delay the outcome of the treatment. Okay. Also, in animal studies, they stimulate a knockout of the cytokines significantly, and it decreases the rate of tooth movement too, significant too. Okay, so the cytokines are very intimate, there is a very close relationship with the rate of the tooth movement. More cytokines, more tooth movement, less cytokines, less tooth movement. Okay, so if we understand, and we also have some studies here, that cytokines can play an important role in activating bone remodeling machinery, the bone remodeling process, we know that, I just keep here pointing 2 articles, but we know that bone remodeling is what allow orthodontic tooth movement to happen, is the basis for it. Okay, if one is important to the other, is normal to conclude, and this is a study done by the New York University in 2010, that cytokines can play an important role in orthodontic root tooth movement. So they create this connection between the presence of these cells and the velocity that we can move teeth. Okay, so the first study, they use what to create this effect? They use micro osteoperforations to create this trauma. Okay, so they are trying to understand the minimally invasive procedure that can cause this effect in a significant way, so we can move too faster. So in animals, they did 3 micro osteoperforations, and then they tested this distalization. So this is a study. If you want to go very deep in this kind of investigation, you can enter in this QR code, download the article, and take a look. Okay, but what is interesting here? Okay, these micro osteoperforations, they are not just a hole in the bone. Okay, they are not just creating with a burn. What we need to do is create fractures in the cortical plate. Okay, by inserting a screw that is going to promote this pressure in the cortical plate and creating this micro fracture in the bone, as we can see here in this illustration. Okay, by doing this compression, this stress, and these micro fractures, what we are doing is starting this process of increasing the levels of cytokines, reducing the bone density because the bone is going to start remodeling faster, and this way we are going to facilitate the tooth to move. Okay, the first study that evaluated patients, it was done in 2013, also in New York University, and they evaluated 20 patients with class 2 with the need for premolars extraction, and they evaluated the cuspid retraction with braces and coils, power arms, and TADs. Okay, so the study pretty much used these biomechanics here with TAD. Okay, in one side it was a split mouth study. One side they did in this area after the premolar was extracted, and after some period to let the inflammatory response reduce, because the extraction itself already promotes a huge inflammatory. So the goal here is to evaluate the effect of the micro osteoperforation alone, and this is why they waited until the healing process of the extraction to finish. Okay, and then they started retracting with a coil from this TAD to this power arm to evaluate the rate of the cuspid retraction. Okay, and what they concluded, here is just a photo to exemplify that the side that was done the micro osteoperforation opened a diastema and reduced the space, distalized much faster than the other side. Okay, so in this preliminary study, let me go back here, they concluded that the movement of the cuspid in the side that did the micro osteoperforation was 2.3 faster compared to the other side. Okay, but here again, a very preliminary study comparing only 20 patients, split mouth, with a lot of downsides in terms of the biomechanics with braces. Okay, but they concluded it was effective, well tolerated, and safe to accelerate tooth movement. Okay, let me move faster. A few years later, okay, in 2018, a group that it wasn't related to the patent, that didn't sell the product, because the New York University, the team there, they did a partnership with the Propel Orthodontics, so they did a study to prove that it works, so they could launch in the market, okay? Then a group of doctors without any bias with this study, without any relationship with New York University or Propel, they did the same study with 60 patients now evaluating the same biomechanics, and they also found that MOP is effective, well tolerated, and safe to accelerate tooth movement. The same conclusion, and for the all 4 quadrants they tested. Okay, so another study proven. And then more recently, studying the effect of micro-osteoperforations on the rate of tooth movement, a systematic review and meta-analysis also from a non-biased team, conclude that the rate of tooth movement was increased after performing MOP. Okay, does it mean that just by doing MOPs, micro-osteoperforation, we are going to solve our problems, we're going to reduce treatment time for all cases? Of course not. As you already know me, if you already saw me in the previous course that I review all the protocols for all kind of malocclusions, and this course in the first lectures that we review these protocols and the diagnostic part, the most important part here is to promote a good analysis of the case, achieve a good diagnostic outcome, to treatment plan the case accordingly, and to perform the case. The micro-osteoperforation is going to come as an addition in relation to all of these good decisions that we did in diagnostic, planning, and performing. Okay, so don't expect that this technique alone is going to solve and reduce treatment time. You need to have all the previous stages done properly, so it can improve the good decisions you made. So this study was done now with aligners. I already showed to you in previous webinars, but this study they did with micro-osteoperforation. Okay, and they evaluated and compared a 3 days aligner changing protocol. The patients who did micro-osteoperforations on the areas that they need to move teeth, they could change aligners in 3 days. And it didn't lose any accuracy compared to the group that didn't do micro-osteoperforation and change in 14 days. It was the same kind of accuracy. Okay, so you may think now, Daniel, are you crazy? In 3 days? Won't we create any root resorption? It's not too many force. Remember, with aligners, we are not going to change the biomechanics. We are not going to change the number of aligners. It's the same protocol. It's the same set of aligners if we are going to do MOPs or not. The difference is that the same force that without MOPs we are going to apply with the aligners, that is going to stimulate teeth to move, that is going to promote bone remodeling, and that we need to allow the time for all the tissues to recover so we can implement a new activation with the next aligners. For this group that didn't do MOPs, that takes 14 days to do this, sometimes 10, depending on the cases, the younger patient 7 as a line, Invisalign likes to preconize, okay? For this group, which they did the micro-osteoperforations, the biological part in the bone happened faster. So the tissues are ready faster to be activated again. So we didn't increase the root resorption because in fact we are reducing the time that this root was in contact with osteoclastic cells, because it's not 14 days for each aligner, it's 3 days. And we are decompressing faster the ligament, right? And these are the 2 main factors that can cause root resorption. Too many force, that we are not increasing force, actually 3, too many force, and this is not being increased, it's the same set of aligners. Too long in contact with osteoclastic, and by reducing the aligner changing protocol to 3 days, we are reducing this period, and also avoiding the roots to be compressed in the periodontal ligament for too long, and by doing this we are decompressing faster because the bone are remodeling faster. Okay, this is an interesting video for a case that I did in partnership with a doctor in Brazil, okay, that we performed to evaluate exactly the same protocol of this previous study, and just to exemplify how simple it is to do this procedure. Okay, here I'm doing very slowly, okay, because everyone is recording, is taking photos, but what is important to see is that it's an auto-perforated screw, very protective here for the tissue, very resistant, that is not going to fracture, and very easily we can do with a minimum amount of blood here. This blood you are seeing here is for the anesthetics, okay? So for this case, we can see that the patient, they can return to their normal routine after this procedure very fast. Just to exemplify, I'm putting 3 cases in the photos in the uppers. The upper photos are immediately after the micro-osteoperforation, so it's normal to see some drops of blood exactly where we did. And here, 1 day after, we still see some signs, but no blood at all, without any suture. The patient completely normal life. Here in 3 days, we almost cannot see where the micro-osteoperforation was performed, and here where we can see it right after. And this other case in 4 days, we cannot see anymore where we did the micro-osteoperforation. So in my experience for my patients, what I normally say to them is that they are going to feel some discomfort for 1 to 2 hours. So if they can go home, stay quiet, and avoid doing exercises, after 1 to 2 hours, they can return to normal life. They can eat wherever they want. They can go to the gym if they want, and it's not going to be an issue. So it's very easy implemented in your routine. Okay. A lot of doctors, they ask me if there is any age limitation. No, you can use for any age. There is no problem using younger patients, although when we have a younger patient and we are using some orthopedic appliance, I don't feel that this is the moment for us to accelerate tooth movement, okay? Sometimes we want to enjoy this opportunity to use the orthopedics effect in our favor. So normally this is the kind of procedure that we are going to do for permanent dentition, okay? When we have all the permanent teeth in the mouth and we want to do orthodontics with brace or liners to level line, correct class 1, 2, 3, whatever, right? So this is the profile of patient that I start using, okay? And if the patient is old enough to do corrective orthodontics, they are old enough for Mops. And is too old? No, you're never too old to do this. And in fact, for older patients where we have a more dense bone sometimes, where we have more difficult and challenging movements, this is something that can help a lot for us to increase predictability and reduce some problems, issues, down effects of the orthodonts like root resorption, recession, and bone loss, okay? So, indications, we can see that for the most important indications, of course, is to reduce treatment time, because if we can reduce the time that we need to use each aligners, we can finish the set of aligners faster and be ready to evaluate the case and be ready to go to the additional aligners if necessary, right? And as you can see, we can have the same kind of predictability comparing 3 days with Mops and 14 days without, which means that it's a huge difference in terms of treatment time for us to finish, okay? Allow complex movement. If we are going to do root tipping, if we are going to do intrusion, this is something that can promote a better bone remodeling, facilitate this complex movement. So it's a good friend for this kind of challenging movements. And control root resorption, as I already mentioned. By creating a better and faster bone remodeling process, we're going to protect the roots and not create more harm, okay? As some contraindications, the situations that we cannot use, patients that are systemic compromise in ASA 3 pattern, so this is not their priority to do orthodonts, so we are not going to do micro-osteoperforation and not even orthodonts in this kind of patient. Patients that needs to use chronically anti-inflammatories and steroids, okay, because you're going to do a procedure that is going to be compromised by the use of these medicamentations, okay, so it doesn't make sense to do micro-osteoperforation in patients like this, and you need to control if it's interesting to also do orthodontics, and also patients who are treated with biphosphonates, okay, for cancer, tumors. So this is the kind of patient that we need to take care and avoid surgical procedures, so probably not a good idea to also do micro-osteoperforation, this kind of case. It's a very, very simple technique, right? Something that you can do easily because it's super safe no problem. The chances to create any harm in the root is minimal. The whole idea is to surpass the cortical plate. This is our goal number one. And we need to insert at least 2 millimeters of the Propel tip, the company who developed this special tip just to do this, okay? Because it's where we have the biggest width of the diameter of the tips, and it's going to increase very fast from 1 millimeter to 2 to create this pressure, right? As we are rotating, inserting inside the bone. And this is what is going to cause the fracture, okay? Why only 2 millimeters? Well, for the maxilla, for sure is going to be enough, okay? A lot of studies are showing that the thickness of the cortical plate in the maxilla is around less than 1 millimeter in all areas, okay? So if we need to surpass the cortical plate and achieve the 2nd millimeter of the screw, for sure in the maxilla 2 millimeters is enough. Why 3 is mentioned here by Dr. Manny Alicani in this article published in American Journal in 2013? Because in the lower arch, we can see that the thickness of the mandible can change and increase from the anterior to posterior. So in the anterior, in this point A is also less than 1 millimeter, point B less than 1, but then in point 3 to point D to point E, it starts to increase, and in the posterior area, in the molars, can reach thickness bigger than 3 millimeters. So for us to surpass the cortical plate, we need to go deeper in these areas, okay? Here, an article that I recommend you to have with you in case you are afraid of doing this kind of procedure, afraid of inserting TADs. This is a study that they evaluated, and they did on purpose, contacting a mini screw in the root of premolars that would be extracted for orthodontic reasons, okay? And they left there the skeletal anchorage for 4, 8, 12 weeks, and then they extract the premolars, okay? So they observed that pretty much 70% of all teeth exhibited good repair by the end of 14 weeks, 12 weeks, okay? So after 4, 8 weeks, all of them, they healed, okay? So we are not talking leaving a screw for a long time. We are talking about a procedure that you are going to insert and remove very fast. And even if you contact the root, probably it won't create any injury in this root, okay? So don't worry about that. Of course, you are going to be precautions. You are going to evaluate an X-ray, a CBCT. Everything needs to be done to check the space and to avoid. Another tip that is very important in this procedure is to not do regional anesthetics, only local, okay, where you are going to do the micro-osteoperforations, only the soft tissue. You don't need to numb the tooth because you're going to use the tooth as your alarm. So if you are getting close to a root, the patient is going to feel some discomfort, and then you don't need to go deeper, okay? So I never had any issues, and I did this in more than 200 patients, so I'm pretty sure that it's something you can easily do. Another thing that I would like to say, and I'm not saying that you only need to use the Propel tip, this one, which you can see the design is more like a cylinder, and this is a more conic. And why? Because a TAD that we use for anchorage, we don't want to create any fracture in the cortical plate, right? We want to keep the cortical plate very tight and firm, so we have a lot of stability in the screw, so it can be used as anchorage, right? And here is the opposite. We're not going to leave this tip there. We just want to create trauma. So it's designed to maximize trauma, okay? So the distance between the tip and the active area where we're going to create the pressure is very shorter, so we can increase and create this pressure very fast to do the micro fractures that we want. And in a TAD, the design is the opposite. They increase the distance between the tip and the biggest width of the screw, so slowly we can increase, and with a much minor pressure, we can insert instead, avoiding microfracture, okay? Also, you need to find a tip. My suggestion is for this one that is sold by Propel, and now Dentsply Sirona bought these assets, okay? So you should contact Propel or Dentsply Sirona. And here you can see that the tip needs to be in stainless steel, surgical stainless steel, because for majority of the cases we are going to do much more than one perforations. We need to perforate and generate this trauma on every area that we want to promote movements, Okay, so we need to use a tip that is safe to do these perforations, and here we have, after 50 perforations, a stainless steel with surgical steel. It can stay without any deformation after 50 perforations, okay, in the mandible, in a very hard structure, okay. Also, it's important that when you use a tip that is not designed to do this, for example, a TAD that is made to use between the roots as anchorage, it's going to be a very conic shape, and we are not going to create enough trauma, as this study presented, this clinical trial, because they concluded that after doing the Mops, it didn't increase significantly the rate of tooth movement. And why? Because they use a device that wasn't prepared to do this. It didn't create enough trauma. Another thing that is not worth using is a burr, because first, we can increase the risk for necrosis. It's much easier for us to create trauma in the root. Okay, we can create trauma in the soft tissue, and it's not going to create pressure in the bone. It's going to remove bone, but we are not going to create pressure and microfractures. Probably if we do a lot of holes here with a burr, maybe we're going to create some inflammatory response, but in a much more invasive way with much more risks, okay? So the Propel tip is going to do this with much less blood, with much more less risk and a bigger effect, okay? Also, if we are using a titanium TAD, even if the design is good, if you can see with the manufacturer of the TADs you are using, but it's not stainless steel, it's not surgical stainless steel, the risk for fractures is very big, mostly for the lower arch in the posterior area. So if you cannot find a Propel tip in your area, okay, but you want to test this technique, I suggest you to look for a TAD, probably the ones who are done for the extravalvular anchorage, okay, stainless steel TAD, okay. This is something that can generate a similar trauma, probably, compared to this tip, okay. And here I'm doing the procedure. This is how we do. It's very fast. Insert 2 millimeters, test, remove. So very fast we can do this procedure. Some blood can appear, of course. You need to be prepared. If you're an orthodontist that you don't like to see blood, maybe it's better for you to refer to your surgeon or your periodontist, I don't know. But I can promise you it's very easy to do, okay? Each micro-osteoperforations can create a 3D effect of about 6 millimeters. And if we consider adding in the same interproximal area between the roots 2 or 3, we are talking about up to 10 millimeters in terms of 3D, like a bubble, a 3D effect around the roots that can be very powerful to promote a better bone remodeling process and accelerate tooth movement, okay? And again, compared to the depth that we need to insert a TAD, that sometimes is almost from one cortical to the other, the tip of the Propel device, of the micro-osteoperforation, is pretty much in this red area, is much less. So we are very far from the root, okay? So you can stay cool and don't need to worry, okay? Take all the precautions I'm commenting here and do with time, patience, and you can see that it's not a big deal. When we are going to use micro-osteoperforation, because everything I'm explaining, you may think, okay, but why I need to use the other technique Dan is going to talk next week, okay? Of course, I'm going to explain better next week, but from now, what I can say is that in my diagnose process, what I want to see is, if I'm moving teeth and the final position of my orthodontic planning is not moving the roots out of the bone, so the movements we are proposing are keeping the roots inside the bone, this is the kind of case the micro-osteoperforations works very well, right? Because what I want to do is to improve the bone remodeling process. I'm moving teeth inside this bone, and that's okay. This is going to happen, and I don't need to be more invasive than that, okay? But if my final position, and now more and more all the softwares are integrating the CBCT with the STL files and our treatment planning software, we can see after moving teeth where the roots are. And if we realize that the movement we need to do, that is the ideal, is moving root out of the bone, then this is a moment that only micro-osteoperforation won't solve this case. You need to open flap and consider doing corticotomies and bone graft, okay? But let's leave it for the next class. Let's talk a little bit about the history of the cases that I did in Brazil and when I was practicing there, and after suggesting to many clinics and seeing some results, also with aligners, okay? I'm going to share a little bit some cases that I had the experience of treating alone by myself and in partnership with other colleagues. And first talking a little bit about the combination of mops and braces. Although this is a liner class, I'm just going to use that as an example because this technique is not seeing what is treating the patient, okay? So when I start researching about this technique, the first cases that I saw, they were performed with braces and the outcomes was very good, right? All the outcomes were very good. For example, this case I saw in 6 months, they could move the cuspid to the final position with a good remodeling process, a good gingival contour. Here, this crowning, solving without extracting in 9 months after doing 2 procedures of micro-osteoperforations, okay, also a great result. To verticalize this molar in 3 months, a great progress, is keeping root inside the bone, amazing, okay? And here also closing this extraction space, although the extraction can promote also a good inflammatory response, but in 4 months to close the space, adding mops, also very good, okay? The issue with braces is that we cannot actually understand exactly how much we are reducing treatment time because we don't have a specific number of aligners to understand how much faster we change the aligners. So it's much more about the feeling of each doctors. And for me, for braces, I like to use to facilitate complex movement and to have more predictability. Another indication, this is a protocol created by Dr. Daniela Storino, an amazing orthodontist from Brazil, which I had the proud of studying with her, and she did this case and she shared with me this complex case about full arch intrusion, the case where the patient has a very vertical face and we need to intrude all the upper arch. Sometimes we can only do this with orthognathic surgery for maxillary impaction, but with her protocol, she saved a lot of patients from orthognathic surgery with great result, okay? So the documentation I evaluated with her presented this characteristic of very long face, vertical divergent profile, some trouble to close the lips, open bite in the anterior, very characteristic for this kind of patient, okay? And then she did, right, this 4 MOPS procedure. When I'm talking about MOPS procedure, is a procedure where she numbed the patient, anesthetized, and performed these micro-osteoperforations in her protocol in the lingual side and the buccal side, between the roots of the posteriors where she is intruding the upper arch. Okay, so the goal here is actually also between the central and lateral because it's a full arch intrusion. And she placed this palatal bar here, bonded in the occlusal surface, okay, and placed 2 TADs also in the lingual, okay, and 2 TADs here between cuspid and lateral. So she can use full-time elastic in this anterior and also full-time elastic from the TADs to the bar to promote this intrusion force of the whole arch. Okay. Also, these bone is also they are used as a tabletop to facilitate and improve the force system for intrusion. Okay. So she did the first procedure of micro-osteoperforations when she started the treatment, and then 10 weeks later, 20 weeks later, and the last one 25 weeks after starting ortho treatment. Okay, so this is the modification after 60 weeks, after 4 MOPS procedure, from this very gum smile to this. Of course, she didn't finish the case. It's also cancer. She continued for some months, and this is the final outcome after the treatment. Okay, so in this case, the information we had and what we measure in the files, initial and final comparing, is that we could achieve about 8 millimeter full arch intrusion. So pretty much something that in the past only can be done with orthognathic surgery. By doing this technique, combining the technology that we have nowadays, the TADs that we already discussed here in the class number 3, the micro-osteoperforations that we are discussing now, it is possible to achieve this amount of intrusion, full arch, and with, of course, with a great control in terms of biomechanics. Okay. This is another case from another doctor, Dr. Glauber Cariñena from Brazil, also in São Paulo, a great orthodontist, and he is using the self-ligating braces and a huge crowding with crossbite in the posterior. So he did a micro-osteoperforations to speed up this aligning and leveling process, and this outcome here we could see just after 5 months. Okay, so after 5 months of treatment time, let me bring again, it could achieve this outcome. Okay, of course this is not the final outcome. This is something that still needs some fine-tuning to finish the case, but a great result in 5 months from the previous crowding to this new situation. Okay, so this procedure, even if you're going to do only one time in the beginning to speed up the process, to get faster to this condition, improving aesthetics and function from the patient, is completely worth it. Okay, even for braces. But where I saw the biggest advantage of using this technique was the combination between Mops and aligners. Okay, this is a powerful combination because in one hand we have here in the left this tip that can promote these micro-osteoperforations to promote a better bone remodeling process. In the other hand, we have an orthodontic system where we can control the force, and we can control the number of aligners, but we can control a lot about our biomechanics. And this combination can really improve and reduce treatment time. Okay, so when I really start using this device, because when I first saw the cases with braces, I was excited, but I wasn't seeing huge difference in terms of treatment time. But when I start seeing, and it happened in the American Congress in 2017, in fact, but I was studying much before this, the cases that my colleagues presented there, Thomas Shipley, Nico Zizis, Belashing Garnett, and a lot of others, they presented me cases with this deep bite correction that you are seeing here crowding in 3 months. Okay, one procedure in the beginning of Mops between the roots, one perforation between each root, and done. These other 52 aligners in 9 months, this big crowding here, class 2, solved in such a short time and one procedure. These other 44 aligners in 6 months. So, whoa, my God, this is great. This is something I really need to test. So in my process of incorporating this in my clinic, I first study a lot, then I saw my colleagues using, then I need to test in some patients, okay? And this is where I start creating my protocol. So the thing that is going to determine if we're going to change in 3 days, in 5 days, on 7 days, the aligners, is the tracking, okay? Because we cannot expect that every patient is going to have the same biological response. So we need to try and test and get some close control. We have a lot of tools to help on that sense, dental monitoring and others. But the thing is that the patient can change in 3 days if for every aligner changing, we can see that the tracking is good. Also, the age, complexity, and periodontal health is going to interfere on that. But in my historical of cases, I could see a lot of cases that I could treat in 3 days, changing aligners in 3 days. Some cases, after some time, I need to increase to 5 days, and other cases including to 7 days, but with much better results. Okay, this is a case that we treat together with Dr. Luciano Wagner in Brazil. Okay, from a aligner system that Easy Solution is the name. It's exclusive cell in Brazil, and the goal here was to correct this crowding. Okay, so you can see it here before and after. This is a treatment that we are expanding. We are not changing molars, so it's a simple treatment, a more predictable treatment. In the upper arch, since we are moving from premolar to premolar, look here in this illustration where I did the micro-osteoperforations. So for a case like this, that I need to move from premolar to premolar, I don't need to extend the micro-osteoperforation to the posterior because I'm not going to move there. It's a local effect. So I'm going to do, I like to use this protocol of 2 micro-osteoperforations between each root, is where I got the best results. In this area, because of the frenum, because of the suture, I did only 1, and all the others 2. Okay, and in the lower arch, As you can see, more or less the same protocol, expanding, aligning, leveling. We did one micro-osteoperforation because the spaces are smaller in the lower arch, and generally I only do 2 micro-osteoperforations between the mesial and distal of the cusp, and now the others, only one is enough. Again, this is my protocol. I saw a lot of doctors using only 1 micro-osteoperforations, and other using 3 micro-osteoperforations in each area, and in my opinion, this is something that works very well. The usual protocol for this case, they usually change aligners in the system in 14 days. This is for every case. They don't have the technology to change faster. And in this case, 18th aligners, we tested changing in 7 days with the micro-osteoperforations. And we could achieve this outcome, okay? Look the difference here. The deep bite, much better. The midline in a good position, expanding the posteriors. In 4 months and a half. The estimated treatment time changing in 14 days. In 14 days, 2 weeks would be 9 months, and we could reduce by half. And now a good moment for us to evaluate, and any refinement is going to be super faster, and the patient is very motivated because it was only 4 months and a half. Okay, so before and after in the occlusal view, the difference in the arch shape, okay, in such a short time. Okay. And then when I start treating my own patients in my clinic, okay, this case actually was performed before this other, okay, but this was one of my first patients. This at the time 44 years, female. The main complaint was lower crown in asymmetric smile. We can see it is that she complained about this unleveled gingival margins, okay, and here this crown in the lower arch. This is not a complex case for aligners, okay? For her, what I planned and my idea was to level the gingival margin in the upper arch, to later complement with a restoration, a composite. My initial thought is to be the less invasive possible for her. This is what she wanted, and me too, I agreed, to only do a composite here to recover the length that is incisor lost because of wear, okay? We are talking here about 24 aligners. Okay, so in a conventional orthodontic treatment with braces and no help of any mops, this is the kind of treatment that I could do in between 12 to 24 months, 1 to 2 years. Okay, with aligners and these 24 aligners in 7 days, I could maybe finish in 6 months. But normally this kind of malocclusion adult patient, I would change in 10, 14 days, can be achieved the first set in 12 months, more additional lines if necessary. The advantage of using the micro-osteoperforations here is that in the worst case scenario, we are going to change in 7 days. I can assure you. And this is something that is the best case scenario only with aligners. Okay, and we still have the chance, if she's very collaborative, if she has had a good biological response, to change in 3 days and be super fast in terms of outcome for the first set. Okay, this is where I did the micro-osteoperforations for her. I concentrated in the anteriors where I need the most important movements, and I simulated. At the time I didn't use DSD, which I could do a much better simulation here, but I simulated how it would be with the composite after all, so she can understand more or less the idea of the treatment. Okay, so here immediately after the first appointment, after doing the mops and inserting the attachments, this is something I'm not doing anymore because I prefer not overloading the patient with a lot of procedure, right? So normally I do the first appointment only to insert the aligners and the attachments and leave the micro-osteoperforation to the second. But here right after the procedure and 3 days after, when I personally change it to the second aligner. Okay, so here in this case I did everything in the first appointment, and in the second appointment I tested the second aligner. So what we can see here is that the aligner sitting is very good, okay, after only 3 days. And she mentioned she didn't felt any discomfort, so she could accept this change in 3 days. Okay, and this case with the biomechanics that we plan, after one set of aligners, after 4 months and a half, 24 aligners, we could solve the main issues, the main problems of the patient. Okay, we could level the gingival margin here with a very simple restorations. Can be better with a veneer, yes, but much more invasive. So here the patient is happy, and let's see how long it's going to last. Okay, later, if necessary, we can change. The only thing I wasn't happy is because of this lower left lateral that in my opinion could be improved, but she was completely satisfied. She didn't want to do the refining at this point, and after all, she came back to my clinic some years later for me to fine-tune this area, but not a problem. Okay, and here the x-rays. With this patient, she changed in 3 days until the aligner 12. Between aligner 12 and aligner 18, he changed in 5 days, and the last aligner she changed in 7 days. Okay, we could keep in a very good condition all the roots without any sign of root resorption. Okay, now I mentioned we can use in young patient and older patient. This is a good example for this lady. At the time, the first time we evaluated her with 75 years in 2012, she didn't want to do orthodonts because she mentioned, I don't have time to lose. I want to do only when can be done faster, and I want to use braces. Okay, and then she came back to the clinic some years after, and I had a chance to convince her to do at least this planification for us to understand better what needs to be done to solve her crowning. Okay, and because she had a lot of restorations and to avoid more complex movement and to simplify the treatment, we added IPRs. Normally I don't like to add in the posteriors, okay, but in this case we did. And I comment with her about this technique that can make she change aligner faster. Initially I didn't comment about this protocol of 3 days aligner changing, but as I was explaining to her, I show other cases that she asked how fast the patients change, and I mentioned 3 days. Oh, it's possible, so I can try. Yes, you can try, but I need to control, okay, and I need to see, and I need to help in that, okay. And then we start, she finally accepted doing the treatment. The problem here is that she went traveling and she never got back after I inserted the aligners, attachments, and did the micro osteoperforations. She went travel, and she only came back to the clinic after finishing the aligners. So I didn't have the chance to control, and she actually changed in 3 days from the beginning to the end. And when she finally got back to the clinic, I was waiting for her, a little bit nervous because I didn't know what to expect. And when they started coming to my office, she was with her daughter. And initially they were with some strange faces, right? Oh my God, what I did. Probably she lost one tooth, probably a lot of recession. I was really concerned, okay? And then when they sit down and we start talking, her daughter asked to make some comments. Okay, please. I was ready to receive a lot of complaint. And then she started talking about the amazing outcome that her mother was seeing, and her mother didn't stop talking during the treatment, how fast it was going. She used a lot. She was very excited. I've been telling her years to do this treatment. Now it is amazing. I'm going to bring my friends. I'm going to do. I was, oh my God, I cannot believe. And I was very emotional in the moment because it's not perfect here. Okay, let's be fair. We need to improve. We need a refinement, and she accepted doing. Okay, but we could achieve this outcome that, although it's not perfect, her main concern about her occlusion, she lost in the period this crown, provisional crown, but her main complaint was solved, and in 3.5 months, right? So amazing. And we are talking about 19 aligners, I don't remember actually, but solving the crowning, the lower arch, an important crowning in such a short time for an old lady. I hope she never heard this, but she's not an old lady. She was works a lot and travels a lot. So, but actually, for her periodontal, her bone, this is amazing, right? And the main reason that it happened is because of her the micro osteoperforation and this planning that we did. Okay. These other cases, one of my most beautiful cases, and the last case that I'm going to share with you today. I already showed this case in other lectures, and I really love this case because this girl here, at the time girl, now she's a big woman, with 15 years, she got to my clinic with her mother. And in Brazil, 15 years is a very important age for the girls because they celebrate, did a lot of events and parties because of this age, right? And they have a huge party plan in the end of the year, and they got to my clinic in the beginning of the year, and well, we need to treat her as fast as possible, okay? And she was complaining about this asymmetric smile, gum smile. She didn't like her small teeth, okay? Looking closer, we can see that there is a lot of discrepancy in terms of volume, okay? And probably orthodontics alone, it won't be enough, what I was explaining to them, okay? So she had a minor class 2 in the right, class 1 in the left, open bite, midline deviation, so not a complex malocclusion. What it was complex is the situation, okay? This overjet, okay, important overjet, the profile was good, so we didn't have margin to retract the upper, so we need to control this. I didn't want to compromise her profile. In her x-rays in profile, we could see that her anteriors in the upper arch were proclined, so we have margin to retro-incline them, but not that much. So in this case, I added also IPRs, okay? So we can promote the correction of this malocclusion by distalizing these premolars and cuspid, okay, and bringing the midline to her right, where it should be. And this set, it was suggested 17 aligners, okay. Normally, I would change this case, if not in 7, maybe in 10 days, okay, this was my protocol, which would bring me to the final outcome in 8 months. Not a long time, right? Not something too bad, okay? But the problem here is that she got to my clinic in March of 2016. And if we started right away, we had only 7 months to October when the party was scheduled, and her mother told me, very serious, she needs to be ready for her party, okay? And also in Brazil at the time, I treated her with Invisalign. It took a lot of time for them to do the documentation, and also at the time I didn't have any scanner, so I need to do impressions and ship to Invisalign. So it took 2 months for us to have the clean check ready for us to plan, okay? So after 2 months, I could explain to them and we could approve the clean check. So now at this point, we only have 5 months to October. So again, 8 months, we are much shorter in terms of time, okay? And it took 2 months for the aligners to get to Brazil, to my clinic, so we can start the treatment. So between seeing them for the first time and having the aligners to start, past 4 months of the 7 we have for October. At this moment, I was talking to her mother and the patient, okay, I understand that we have the party in October, but we need to do orthodontics, and in the end, you want to do some whitening, and we need to adjust the gums with some crown lengthening to balance the proportion. We don't have time. The only way we can do this, if we need to do this technique that I am bringing from United States, and luckily I just came back from California, where I went in February. I went there to visit Propel. I bought a device to test in my clinic after seeing all the cases that I showed to you in the beginning. And at this moment, I had there, okay, I wasn't expecting to test so fast in a patient that is not a patient from my family, a friend, but this is the only solution. Are you open to do this? Her mother, yes, we need to do. She really wants. I want her to have the best smile there, okay? So these 8 months that these 17 aligners we need to do to finish between this month here to 1 month at least before October, we have only 2 months, okay? So here in the same table I was explaining, and when I start talking about conventional ortho, okay, you can stop there, I don't want to do this. And then with aligners, we could finish probably in 4 to 5 months if she's really collaborative to finish 17 aligners, changing in 7 days. But even so, it's not going to be possible to finish on time. So I draw these, okay, here, the only chance is if we use this technique and you be very collaborative using the aligners. So we can change 3 days, okay? I did in these areas, okay, this protocol that I use for a lot of cases after this case, 2 micro-perforation maxilla, 1 in the midline, in the lower arch, 2 near the cuspid, and 1 in the other areas. Okay. Here, after 3 days, when I inserted the aligner number 2. Okay, so it was my post-operative control 3 days after inserting aligner number 1 and doing the micro-osteoperforations. Okay, and here I could see that excellent healing. I cannot see practically what I did in micro-osteoperforations. Good tracking of the aligner number 3, and the patient wasn't complaining about pain. So I said, all good, let's keep changing in 3 days. Okay, since it was one of my first cases, I tracked her, monitor her every week practically. And after 17 aligners, 51 days of treatment, less than 2 months, I could finish the ortho, at least for this set, and I refer her to my colleague who's going to perform the whitening after the crown lengthening. Okay, so here after 51 days, the midline is corrected. Okay, the open bite we solved, and initially it was expected for us to finish this in 8 months, 17 aligners, and we could finish in 51 days with only procedure of micro-osteoperforation in the beginning in the areas I commented. Okay, and of course orthodontics alone cannot do. We could improve a lot the smile frame, the incisal edges, but the small crowns and the asymmetric level of the gingival margin could only be solved after the crown lengthening. So look the difference between the initial smile and this smile after 2 months, right? And here we can see a great occlusion, right? A great outcome, a great healing, a great periodontal condition. Of course, this patient helps because very young, okay? But we are talking about 51 days of ortho and then 30 days to do crown lengthening and whitening, okay? Look the occlusion in a closer view. Initial the comparison between what it was planned and what it was achieved in terms of arch shape, and here her smile in such a short time. So if you pay attention, it took much more time from the moment I saw her to the first time to the moment I received the aligners after planning and ordering the aligners. It was longer this period than the period that it took for us to do all the ortho of her, and now the whitening and the crown lengthening. So this is amazing, right? Because right now in Brazil we can receive aligners much faster, and in cases like this we can finish really, really fast, and it is great for the patients. This patient and her mother, they did a lot of merchandising, free marketing for my clinic because they were really surprised about this outcome, okay? She came back after 3.5 years for a control in 2020, okay? So we still have a beautiful smile. We had a minor relapse here because she confessed she was using the retainer, and then was very angry. But we ordered additional aligners. It was included inside her package up to 5 years. So I ordered to just fine tune, and now she's using the retainer correctly. Okay, no sign of root resorption, no sign of any issue, and changing in 3 days. Okay, so this is something that I really like to encourage you to study more. I know 1 class, 1 hour is not enough maybe for you to start using tomorrow. Okay, I share with you some articles and reference that I really think you should study these articles to understand more. I'm available now to answer questions, okay? And before I move to the last slide with my contact again, just remembering, if you are just joining me for this webinar here, you can also check the full program of 8 modules. And the next class, I'm going to talk about the surgical facilitated orthodontic treatment with corticotomies and aligners, with and without bone graft, okay? Then we still have ortho-orthogonatic cases and ortho-restorative cases with aligners. So thank you so much for your attention. I hope you enjoy this class. This is something that I really like talking about, but because my experience is very good in my patients, and I study a lot this topic to bring this technique to Brazil. And now here in Spain, discussing cases with clinics all over the world is something we have been using for several cases, and I hope you can be encouraged to start using in the near future. Okay, I'm going to wait for some minutes in case you have some question to do now. If you are not in the will to do any question at this moment, you can make any questions you want about this topic, about any other class of this course topic in other moment. Okay, you just need to write to the OIGS team. I have my dear friend Valeria always forwarding these questions for me, and I try, Valeria, you know it, right? I try to be as fast as possible to answer and in the most complete way. Okay, I'm going to wait a little bit more. How we have right now, we don't have any questions, so let me keep talking about it. Just some fun facts, because this technique, before Propel launched in the United States, they really investigated. They didn't precipitate, they didn't anticipate any launch before they have a very comprehensive study, not only in animals, but also clinical. Okay, so it took them about more than 5 years to develop these studies. And when they launched it in the American Orthodontic Congress, AAO Congress, United States, in 2016, Orlando, okay, sorry, actually 2015, they already earned the award of the most important technological launch of the year in the orthodontic field. And after this event, they increased the amount of cases performed, mostly in the United States at the time where they launched it, in an exponential way. So they achieved very fast a lot of cases performed, and this is something that I really value when I decide to go there to see with my own eyes, to look for a technique that can really help my patients. Okay, so I hope you can use my experience to shorten, to do a shortcut in this journey and don't take so long for you, because this is something that is very tested and very proved, and my experience saying that it's worth implementing. Okay, a polemic topic though, because when we talk about accelerated orthodontics, we need to understand that there is no magic here. Okay, we need to understand that you still need a good orthodontist behind, a good doctor making good decisions in the diagnostic, in the treatment planning, in the decisions during ortho treatment to make it happen. And this is only an addition, only an extra that can help and make the experience for everyone a little bit better. Okay. Team, any other questions? Not other, because we don't have any, but if there is any question, I'll be glad to answer now. If not, I hope to see you in the next class. So please let me know. And then if we don't have, I'm going to say goodbye now. This is my Instagram if you want to get in contact with me and follow everything I'm doing in terms of orthodontics, in terms of the clinical manager here in the Digital Smile Design Planning Center in Madrid. So I invite you to follow me there so we can be closer. And in 2 weeks, we are going to talk about the third part of accelerated orthodontics and bone modulation, the surgically facilitated orthodontic treatment with cord economies and aligners. See you there.